systemic mycosis. So far we talked about superficial mycosis, subcutaneous, cutaneous. And as the name suggests, this is a deeper form of mycosis where fungi are invasive. And again, as I said in the morning, these are the dimorphic pathogens, and I told you why they are called dimorphic, because they have an ability to exist in two different forms at two different temperatures. At one temperature, they will exist as yeast, and the other temperature, they will exist as molds. Now, three are more important than other: Blastomyces, Coccidioides, and Histoplasma capsulatum. So these are three important systemic mycoses that we normally see. And let me show you how do they look like in terms of their morphology. And you can see from here, again, I want you to appreciate the fact that on the left-hand side column says 25 degrees C, and the right-hand column says 37 degrees C. And you can look at the saprobic phase on the left-hand side as compared to parasitic phase, which is on the right-hand side. And this, again, number A, as you can see over here, is Histoplasma capsulatum. B is Blastomyces dermatidis. And C is Paracoccidioides brasileus. And number D is Coccidioides imitis. And then number 4, like in this E, is Penicillium momphigi. So these are some of the important endemic dimorphic fungi, and you can see from here that they do exist in two different forms, and they are temperature sensitive. Now the question is that how would they enter our bodies and where do they go? We already talked about the entrance to our bodies are either skin or mucous membrane, and both skin and mucous membrane are connected to lymphatic system and circulatory system. And again, routes of entry like bacteria, viruses will determine as to where these fungi will lodge in and cause damage to that particular tissue. Now again, on the left-hand side, you can see routes of entry could be nasal sinuses, and from nasal sinuses, they would end in lungs. You can have an injury or a catheter being put into you, and via that, it can enter into your bloodstream. You can also ingest. So esophagus, stomach, intestine, and then again, skin remains as important aspect over here. Now, if you look at the differences between the deep mycosis and cutaneous mycosis, again, three forms of cutaneous mycosis that I discussed earlier. Superficial is the one that stays on the skin, hair, and nail. Cutaneous, again, skin, hair, and nails. Subcutaneous is beneath the skin, so it doesn't involve hair and nails. When we talk of deep mycosis can occur in brain, lungs, heart, spleen, liver, and kidney. So basically, they are these organs that come in contact with either lymph in lymphatic system or come in contact with blood. Now, you can see from here, as we discussed earlier, conidia. These are those small particles we call spores, and this is a typical fungal mycelium, and in this case, infection is occurring by you inhaling endospores. So endospores will go into your system, and you can see that they will reside in different parts of the lung. And depending upon which part of the lungs they would reside in. They will exist in the form of endospores. So they will be inhaled in the form of spores and then lodge into the lung tissue in terms of deposit, and then they keep on depositing in the tissue, divide, and replicate. So that kind of a replication and systemic spread is in the lungs. So that's a typical situation that normally see. If you want to look at, for example, where exactly different types of the deep mycosis occur, and you can look at the inset over here, again talks about the Blastomyces, histoplasma, and histoplasma capsulatum, coccidioides, and the rest of the fungi. And then you can also look at some of the worldwide countries, especially eastern United States, has a high incidence of Blastomyces. And then also in South America, Brazil and other parts, and then again Far East also have a higher incidence as compared to the rest of the world. And again, rest of the world, according to this picture, seems to be free of that particular fungi. Now again, I just want to emphasize the nature of temperature, and when the fungi spore are from the environment and they are getting into the warm-blooded animals. And this is how the whole cyclic nature happens in terms of either an animal habitat or a natural habitat. So if you, for example, pay attention to the right-hand side, there where the spores are formed, they bud out, and yeast is primary the mode of spreading, and the temperature again in this case happens to be 35 to 40 degrees C. So that's a typical animal habitat. When you decrease the temperature and take this particular fungi into environment, then that's where they call it saprobic. Saprobic means free living. And the temperature is less. In this case, reproduction occurs through sporulation, hyphae are formed, and again spores will be formed, and then this cycle will continue. If you look at different specimens that we normally see that are tested from different patients, you can see sputum is number one. This is how we process the sputum. And blood, cerebrospinal fluid, pus, vaginal secretions, hair, skin, nails, and then finally we have other tissues, tissue biopsies, and so on and so forth. So you will see a common theme among them, that microscopy, culture on Sabouraud's agar, and then some of the genetic techniques that we normally do are the main one that will differentiate as to what specimen we are looking at. And once I begin talking about the clinical aspects of that, and if you remember, I think, if I remember correctly, bacterial vaginosis was one of the cases that you did as an STI, and one of the causes for that was Candida. So Candida remained as one of the common cause of vaginitis and very high incidence and difficult to treat in women. And then again, as I said earlier, HIV and other immunocompromised people may have a challenge. So this table will give you an idea as to how we process and what are the different, because remember that we are taking a specimen, for example, let's give an example for vaginal secretions. So it could be bacteria as well. So we have to make sure that we differentiate between bacterial infection as compared to fungal infections. So we really have to process the sample as such to differentiate between different causes of bacterial vaginosis or vaginosis, as a matter of fact. Now again, some of the slides I'll take you through how we acquire And where are these fungi coming from? Again, I want you to pay attention to number A, which shows that there's a soil that's containing bird droppings, and that soil is whipped, and then you happen to be running, you happen to be in the farm, you happen to be in the farm, a ecosystem where you will inhale these microconidia. So they will go into you and make you sick. So you can see a very benign environment can make you sick, and then these conidia will divide into your lung and may lodge in any different parts of your liver, heart, bones, intestine, kidneys, and so on and so forth. So this is a typical scenario for some of the deep mycoses. Yet another scenario is that you are digging the soil, and then again soil produces aerosol, and they are arthrospores. So these are now arthrospores as compared to conidia that you saw in the first one. So arthrospores, again, you will inhale, they'll go into the lungs, they will divide into your lungs in terms of endospore, and if you happen to be compromised in terms of your immune system, you may lodge this arthrospore in your brain causing meningitis, or in your bones causing osteomyelitis, or in your skin causing skin granulomas. So you can imagine a scenario which is pretty common, pretty easy. This looks like normal daily chore of life, a routine, but people may end up in trouble. Repeat slide. I told you the challenge for therapy again happens because fungi are eukaryotic, we are eukaryotic, so whatever you're going to give is going to cause tissue damage as well. And then I'm not going to go in detail, but as we go for the clinical aspect, these are some of the charts and some of the tables in your book, and I'll just try to help you out how to interpret this table and how to understand what is going on in so-called complicated, seemingly complicated table. So you can see it is characteristics of endemic dimorphic mycosis. So we talked about all different type of mycosis which are given in terms of causative agents, and what precisely is the name of that fungi, and how do you acquire that fungi in your ecosystem, and geographic distribution if you happen to be in that particular country or area, and then again once they lodge into the tissue, which tissue are you looking at by tissue biopsy, and what are the clinical presentations. So what I want to point out over here is that we talked about meningitis, we talked about osteomyelitis, we talked about granuloma, we talked about kidney problems. So always keep in mind when a person presents with inflammation of any of the vital organs, fungi also remain as one of the important differential diagnoses. So you can see from here, as I said earlier, physicians are trained to think green, and green in this case represents fungi. As we've been discussing earlier, the dimorphic nature of these fungi that causes systemic mycosis, and they basically are acting in two different forms at two different temperatures. So when we have to isolate them, we isolate them in a different form, and then we grow them in different form. And the whole group are considered as primary systemic pathogens. The reason is that they have this ability to cause infection in both normal and immunocompromised host. So don't think that, remember there are two factors, one is a host factor and one is a fungal factor. So in this case, if fungi even are non-pathogenic, they can still cause infection in an immunocompromised host because the immune system is compromised. For the systemic pathogens per se, even if you are normal and your immune system is normal, they do have the potential to cause disease. So they are real pathogens. They're not opportunistic pathogens. And you can see once they go into the system, they have this ability and propensity to invade the deeper tissue and then again cause the problem. Now, we call them primary pathogens. We also call them endemic pathogens because they can go and cause systemic disease. So they can go and involve any of the viscera that we have. And the same organisms that we talked about could also be opportunistic as well, especially Histoplasma capsulatum and C. immitis. These are two important fungi that are related to AIDS patients because they basically are immunocompromised. The other important thing you have to keep in mind is that if you happen to live in an area where you are normal, but there is endemic nature of that particular fungus that is present in the soil, in the ecosystem, so there are good chances for you to acquire that and then complicate or challenge your immune system. So the point is that if you happen to live in an area where fungi are endemic, even if you are normal, there are chances that you can get disease. Does that make sense? Yes, no? So if you are sick, you are immunocompromised, you're going to get disease anyway, even with less pathogenic fungi. But if you are normal and living in an area where there's endemics already present at a constant rate, you always have a chances to acquire and get endemic mycosis. Now again, these are some of the slides. When you look at those scrapings, you look at those tissues, see them in the microscope, and you see those forms that you normally see. So when I'm going to give you the clinical cases, so the charts will show these actually hyphae or conidia. And I do think, are the P4 students here? We will send you quite a few practice exams as well, so you pretty much get used to what type of hyphae and what type of molds are there. But they're very obvious. Once you remember those charts, it will be easy for you to remember. For example, in this case, you can see on the right-hand sides, you see polymorphonuclear neutrophils, and you can see those little tiny dots over there, and these basically are the ones that are there and being phagocytosed by neutrophils. Sounds like French, right? I look at your blank faces and I feel like, what's going on? So anyway, just bear with me, and that's the way it goes. But I'm pretty sure, that's what I said, we just wanted to add a clinical aspect to that, so you basically are not bombarded with tons of information. You only are bombarded with something that you may happen to see in your lifetime, or if you work in ID, okay? But get used to these terms. They are pretty common in infectious diseases world. And again, you can see if you want to practice in those areas, especially east side of United States, Southern America, where it's pretty much common. And once I do this clinical part as well, I will show you some of the reports, daily reports, or even if you look at some mainstream media, they do report systemic fungal infections. And also worldwide, again, as I showed you, that there is a belt over there, especially for Blastomyces dermatitis causing Blastomycosis. We already talked about this ability of dimorphic existing in two different forms. I don't want you to remember per se the size of it, but if you, I just told you, it's like a common sense question. If I told you that those small conidia are phagocytosed by neutrophils, so what do you expect their size would be? What is the size of neutrophil? That's interesting. What is the size of bacteria? 5 micrometer, right? And if neutrophils phagocytose bacteria, they have to be larger, right? About 10 to 12 micrometer. So if you have that size in your mind, of course, viruses are even smaller than that, okay? So anyway, And then again, also keep in mind that basic physiology, for example, the pores of respiratory membrane that separates the air from the blood, and then the size of glomerular membrane that separates blood from the urine. There are sizes over there, and there are pores over there, like they are sieves and filters. So if you remember the size, for example, if proteins start appearing in urine, what does it mean? Of what? Okay, you are a pharmacist. You have to go a little bit in detail. We are talking about inflammation of glomerular membrane. It's a Bowman capsule. You're talking about glomerulonephritis. So you know that where exactly glomerular membrane is. What are the three layers of glomerular membrane? When it gets inflamed, the sizes, pore size enlarges, and proteins normally pass through. Right? So it's a little bit more detail that you have to remember. It will be easier for you to have a concept in terms of why the protein starts appearing in urine. Okay. Again, this is a natural history of a mold. Again, a saprobic versus yeast, which is parasitic in terms of Blastomycosis. And again, you can see in this picture over here is that in an ecosystem, we have trees, we have animals, human beings. So all of these three can come in contact for fungal infections. And then the important thing you will see on the right-hand side is that 25 degree, and then it becomes inhalation into the lungs. Lungs, we have 37. And then again, when it goes into dissemination in macrophages, that will be the beginning of infection. And then again, back and forth, this typical cycle of inhalation, returning to soil will come if you are infected. As I've been saying over the last couple of months, I would say that it doesn't really matter what is causing pneumonia, whether it's a bacteria, virus, fungi, or parasite. Parasite would really cause that though. Once you know it's inflammation of the lungs, you pretty much know what are the consequences of that. Does it sound like a familiar thing? Right? If it's a glomerulonephritis, all you need to know is, that's why we teach you physiology first, what is the function of that particular organ and where exactly the function is taking place, how the function is compromised. Okay? And then the rest of the things pretty much are the same. Okay, because if your lungs get filled with fluid, and if the respiratory membrane gets thickened, what will happen if respiratory membrane gets thickened? Basic concept of physiology.
Doesn't it include respiration?
Correct, but yeah.
You can't breathe in air because you're disrupting the pressure.
Well, you just think, you are right, I'm not saying you're right, but thing is that the transport of oxygen is occurring through respiratory membrane. And this has a defined thickness. When the thickness increases, that kind of transport cannot take place. Okay? So, thickening in the lining, whether it be because of connective tissue disease, whether it be because of infection, inflammation, would make the job of oxygen saturation cumbersome. So you will have less oxygen saturation to such an extent, if your whole system is compromised in terms of pneumonia, they may have to give you oxygen or put you on ventilator. Okay? But the good thing is that for most of the natural function, you got 2 lungs, 2 kidneys. So these organs are vital organs. So if one is not working, the other will compensate for that. But some of the organs are standalone, like liver and spleen and so on and so forth. Okay? So you can see when we talk of the clinical picture, what it's trying to tell you is that regardless of whatever causative agent is, there is a compromise in the function of that particular organ. And once you got compromised, that's why it's good for you to have a concept. So whenever you lose the function, what eventually will happen? So that's what you need to know. Okay? And as far as diagnosis is concerned, you can see from here if it's a pulmonary infection per se, So for pulmonary, you have to do sputum, you can do bronchoalveolar lavage, you can take lung biopsy, and that is a standard procedure regardless of what is causing the infection. And then again, for cerebrospinal fluid or urine or pus, all you need to do is, again, as I said earlier, use chalcoflower white and look under the microscope, and you will be able to see the different types of fungi causing problems. Again, for this particular fungi, especially Blastomycosis, we see a broad-based budding yeast. They are present. So that's kind of a diagnostic and a very definitive kind of treatment, diagnosis, if you look at the scraping under the microscope, is very obvious. For treatment, same choice. Since this is a endemic or systemic thing, so we will immediately resort to oral antifungal drugs, as simple as that. So we will have a treatment, as we discussed earlier. The most important is amphotericin B. That's the agent of choice, and then again depends upon the other therapeutic success rate. We can either add azole therapy as well, and it's very common, especially in AIDS patients, that we put them on long-term suppressive therapy with itraconazole. And since the problem remains, so they will have relapses. What is a relapse? Comeback. Exactly, this infection will come back over and over again, because we sometimes put them on a what you call a long-term maintenance or suppressive dose to fight those fungi. This is again a natural history of Coccidioides immitus. Again, you will see the same picture in the environment. Probably shows cactus, or probably it's more in Arizona. But again, eastern bloc is more where you'll find a typical structures that can go, and you can look at the size over here. It's 5 micrometer because of the branching pattern that you see. And then again, lungs and air and environment. So pretty much an area where, and again, if you look at weather report, for example, so you'll see in weather report they talk of allergens. They also talk of some of the molds and the yeast and some of the fungi present if it happens to be an endemic. And the other important thing, that if I was to ask you the difference between coccidioides and then blastomycosis, was in one of these, especially the blastomycosis, there was an animal involvement as well, as compared to this one, which we normally don't see that. So that's another. And sometimes it could be pets, it could be warm-blooded animal, and many times it's birds or bird droppings. So that's also important. So in this case, for example, you can see Histoplasma capsulatum. So there are birds there, especially bats. So they have these bats dropping in that environment, and you happen to be there, you will inhale it, and they will then exist either in the form of mold, saprobic, and parasitic yeast, because they are going to divide in your cells. And then you can see from here, the cells are there, especially monocytes and macrophages divide into that, and then split off and spread. In this case, a typical scenario, which happens to be the natural history of Histoplasma capsulatum. What I have is, especially from another book, and I'll post it up tonight. So I have a comparison. My slides don't show that. So I'll have a comparison between the deep mycosis, so you can compare the causative agent, you can compare the temperature, you can compare the diagnostic tests, and how do we differentiate in terms of their clinical features. And the last aspect for mycosis, the text part, is opportunistic mycosis. And again, as the name suggests, I'm pretty sure that you are familiar with this concept of a microorganism being opportunistic. So you give the opportunity to that microorganism, and then it will do the rest. So classically, for fungi, we have 3 types of opportunistic infection. And number 1, Candida. As I said, Candida happens to be the number 1. And then there was a time that we learned that there's a non-Candida. So we put only one fungi into Candida. It's called Candida albicans. Very common, and I'm going to talk about that in detail. And then when we thought of any other microorganisms in this group, Cryptococcus neoformans. So that again is very important for HIV, Cryptococcus neoformans. And if there is anything else beside these 2, we call it non-Candida, non-Cryptococcus. And there are 2, or actually sometimes people think that there are 3 as well: Aspergillus, Zygomycetes, and Pneumocystis jirovecii. So these are the 3 non-Candida, non-Cryptococcus. So this is a basic classification for the opportunistic fungal infection. Yes?
Is this the same Candida that you mentioned for cutaneous mycosis that involve female?
Did I mention what?
You said that in cutaneous mycosis you had the epidermal phyton, microsporum, trichophyton, and Candida. Is this the same Candida?
Well, most of the Candida could cause infection, yes. But what I said was that one of the STI was bacterial vaginosis, and the most important bacterial vaginosis cause of vaginitis is Candida albicans. So that's more important for you to know, because one of the commonest things that we see in females, especially with problems of vaginitis and vaginal discharge, is treatment of fungal infection. So fungal infection in female in terms of causing vaginitis or causing vaginal discharge is the most tough to treat. So that remains a challenge even today. Okay. Now, opportunistic mycosis, of course, could be invasive. And when we talk of invasive mycosis, we also immediately start thinking of high-risk groups. So you can see the high-risk group in this case happen to be those people which are blood and marrow transplantation. Why do you think that they are high-risk groups? Why do we have bone marrow transplant patient, or as a matter of fact, solid organ transplant patient, to be considered as a high risk of developing invasive mycosis or opportunistic mycosis? Say it again?
Because aren't they on drugs that will suppress their immune system?
Well, you have to say steroids. You cannot say drugs because you're a pharmacy student. So you have to say because they are there on steroids. So you have to be pretty much certain that they are steroids, and that's what causes the, and there's a long-term steroids. Actually, that's the correct answer. And then major surgery, AIDS, immunosuppressive therapy, advanced age, because when you grow old, your immune system wears out as well, and premature birth. We did not talk of one thing, but I just told you that that also happens to be considered as a high-risk group. And what is that? Of you developing opportunistic infections. Just a second ago, in reply to your answer. STIs, I just told you that Candida is considered as STI, sexually transmitted infection as well. So those people who happen to be in that group may also have a problem of acquiring fungal infections. Okay, now 3 important. Candida, and we just took one from each group, that's what it is. So 3 groups: Candida, non-Candida, non-Candida, non-Cryptococcus. And we picked up one from each group. Candida albicans, number 1. Cryptococcus neoformans, number 2. Aspergillus fumigatus, number 3. Now the annual incidence is you can see about 72 to 90 per million, especially for Candida, 30 to 66 for new formans, and 12 to 34 for Aspergillus. And these are incidence by far in USA. And then again, as I said earlier, that physicians are trained to think green and think fungus. So if you do see anything which may pose a problem in terms of a diagnostic or therapeutic challenge, make sure that you rule out fungal infection. So that's something you have to make sure that you rule out. Don't leave it alone. And then again, problems that we have in treatments of bacterial infections and viral infection still come and haunt us, especially for fungi, because some of these organisms that I just mentioned happen to be inherently non-susceptible to standard antifungal therapy such as azo. So we may have to go for alternative antifungal agents, and many times we may want to go for surgical management like debridement, or sometimes we may want to boost your immune system. So that's another important thing if your immune system happens to be the case. A little bit detail. I think my plan is to give you the case history for Candida. We'll pick up typical cases and I'll take you through that. But just to complete the lecture part, Candida again is number one, is the most important. And also remember that Candida species are the fourth most common cause of nosocomial bloodstream infections. And that's even more severe than gram-negative pathogens. I told you earlier the challenge was gram-negative bacteria pathogens, but Candida has stood even higher than that when it happens to be nosocomial bloodstream infections. Can you make a guess? Why would that be? What are nosocomial infections? Hospital acquired. So why would people in the hospital will get opportunistic Candida infections more than even gram-negative infections? Sorry? Spores? Hospitals are pretty much clean, I believe. You're not supposed to have, sorry? AC units. You're talking about Pseudomonas. I thought you, yeah. Okay, anything else? Common thing, yeah. Patients are bedridden. Well, they are bedridden, yeah.
As part of the normal flora, and in the hospital, the patients usually are immunosuppressed, and also the amount of antibiotics going on in the antibiotics could generate resistance in Candida.
So if patients have surgery and since it's in the bloodstream, does that correlate?
Well, just keep in mind, because we use invasive procedures. So everybody who sits in the hospital, he's injected with a Brenella, a cannula, injections. So they are being poked in. That's what it is. So if you want to poke the patient, vessels and veins, and if you have urinary retention, they're going to poke urethra. All those kind of scopies that are taking place, and all those kind of things that they're using into the patient. Invasive procedures, of course, would give a chance for. But then again, what you are saying could also be the reason. Okay, now there are 100 species. You can see sometimes the complexities that we have in terms of treatment. We just teach you one, but basically there are 100 species. And the good news is that albican basically is there, especially for mucosal isolates. So basically, for mucosal isolates, I would say sputum, urinary, urethral swab, vaginal swab, anal swab, all these mucosal sites which are open to exterior account for most of the stuff. And again, for BSI, bloodstream infection is also there. When we talk of, I think out of 100 we just want you to remember 4. And I usually, whenever I teach that, that reminds me of Starbucks coffees and different names that they have, lattes and this and that. So a glabrata was the number 1 that you want to remember if that happens to be a mnemonic. Parasilosis and tropicalis. So that's like more of an orange ring. But these are some weird names that you may have to remember, and I'm going to give you a little bit of clinical aspect for that. Candida albicans, Candida glabrata, Candida parasilosis, and Candida tropicalis. And especially for glabrata, which is again coming as the major cause of bloodstream infections. And again, the other important thing for that is it has the ability, it is acquiring resistance to azoles. So that again, I remember we played this workshop, the genetics of bacteria. How would bacteria pick up genes for resistance? So you can see the way things are moving, most of the drugs we are teaching you are going to be obsolete because none of them is going to work for any of these microorganisms. So if you want to stay in the business, you may want to go and do a little bit of research and find out what is it that is causing it and how are we going to take care of that. For morphology, again, sizes is small. They produce buds or Blastomycosis. Species of Candida other than glabrata is the one that does not produce a pseudohyphae but produces a true hyphae. And then again, one important thing, because it's very common, that Candida albicans forms germ tubes and a thick wall Chlamydia. So these are 2 important things. If, for example, you given a case and say identify the causative organism where the report comes that this fungi has an ability to form germ tube and terminal thick wall Chlamydia. What will be the answer if you're given all those 4 different types of Candida? Candida albicans, of course, Candida albicans. Now you can see number A, budding yeast, number 2, pseudohypha, and this is how the germ tube looks like. This is like a germ tube, it's called germ tube, and the true hyphae. Okay. Now, if you want, I remember this concept, I don't know whether you remember it now in immunology, we talked about phenotypic switching. Does anybody remember what was that? Phenotypic switching in immunology? No. Why are you pointing to him? Okay. Isotype switching, remember, or phenotype switching was that normally the B cell produce IgM and IgD normally to be put on B cells. So you want to cause switching after infection so they can also produce other types like E and M. So this is called isotype switching in terms of immunology. So same concept we call phenotypic switching in Candida. So what normally happens is that it has, most of these fungi has the ability when they divide, they form a typical, one strain will form a typical kind of a colony, right? And this happens to, in this case, for Candida albicans, they have the smooth, white, creamy, doomed colonies. And single strain, if it has the ability to change the morphotype, so they can go from one to another one, which happens to be a budding yeast-like and becomes fuzzy and hairy and form hyphal form. So this is like a colony differentiation that we have in terms of Candida. So Candida can switch on and switch off. And why do we need to, what do you think could have happened? I mean, most of you were there in the workshop, right? If I tell you that this is important, now you have to tell me why is it important. And what comes in your mind when I tell you that Candida albicans has a quality of switching the morphology of one colony form to another one? Well, that's true, but what exactly is happening in terms of workshop that we did?
It can pick and choose which one to carry forward and which one it increases.
Okay.
Like transformation?
Well, it's not transformation, it's mutation. Remember, one of the questions in the test was, what are the ways that you change the strain of one organism to another one? Right? So one of them was mutation. So this means that this has capability to mutate. So if it mutates, then we have a problem, right? Because the treatment-wise, we'll have a problem in future if the microorganism is mutating. And you can see from here, the frequency of the switching phenomena is too high to result in gene mutation and too low to be attributable to mass conversion. So if you remember the chances that we discussed in terms of mutation causing problems. Normal mutation do occur in all human beings, but the incidence is too low to cause any obvious effect. Does it make sense? Okay, but you can see that the postulate that we have is that phenotypic switching is where the ability of the C. albicans to survive in many different environmental micro-niches within the human host. I told you one of the problems that we have, if you will go to the clinical practice, and it's all over the world. I've seen it myself. It's all over the world, especially fungal vaginal discharge, treatment of women for fungal vaginal discharge, and because of the Candida. And one of the reasons, of course, is because Candida has an ability to mutate and change. And then we have a challenge in terms of treatment, because we don't want to give them oral antifungal drugs, because oral antifungal drugs will have other side effects as well. So anyway, they are found in human and nature. The other important thing you have to keep in mind is that Candida species are also considered as normal commensals in the vaginal and urethral flora in females. That's another challenge that we have. So that's why we include that in terms of opportunistic infections, especially if the use of antibiotics or use of some other things may change that. Okay? Now, if you look at the statistics over here, we talked about high risk, and then again, exposures. I just told you that these are the exposures. Why would antibiotics lead to this opportunistic infection? Because it changes the normal flora. So that's what is happening. And then again, if you look at the bloodstream infection, you can see 49% as compared to 39 and 12. And not only that, it even is causing death. And death due to Candida bloodstream infection. This used to be rare. But you see that now the statistics are coming up. What do we mean by endogenous infection? As I said, if Candida is your normal flora, right? So you are yourself giving your own flora to cause infection to yourself. It's not exogenous. It's not coming from outside. Your own flora is taking advantage of you if you're giving them an opportunity. As compared to exogenous, where it is coming from outside. So it can come in irrigation fluids, parenteral nutrition fluid, so on and so forth. So anything from outside goes in. Lab diagnosis, pretty much the same. I already told you, I'm going to show you how the Candida looks like when you grow them. And that's a typical picture of Candida. And you can see the fluffy and different colors over here. And I would stop here